talk about in just a moment. Now, this is not always the case, and often this requires adjusting, specifically in patients with high airway resistance, which I will talk about in just a moment. But as you can see, the drive is normal, 2.35 of a P0.1 measurement. Now let's look at the patient with a high drive. Now the P0.1 has gone back up. And similar to pressure assist control, you just see more rounding in the flow waveform here. However, the cycling off seems to be still reasonably okay, but there's a little bit of dampening here in the expiratory flow. This can be addressed by simply lowering the cycle off criteria to a lower level. Let's see how that works. So you can see there's less dampening here. So that's one way to manage it. However, little adjustments like that are less likely to reduce the patient's drive. So it's more important to try and increase the pressure support to a level that may reduce their drive. If they respond to the increase in pressure support and the drive decreases, as it does here, then as you can see, the cycle criteria is good. And let's increase it back to 25 as well. You can see it still looks good at the normal default setting. So what you really want to do is try to reduce the patient's drive. However, if increasing support, which increases tidal volume delivery to the patient, does not decrease the drive, you really have to be concerned whether or not the patient is causing potential injury to themselves. Now this patient is on a moderate level of PEEP at 10 centimeters of water, and the FiO2 requirements are 50%. So this patient having a very high drive is actually concerning. So you want to keep the drive in this range. So this is an okay and acceptable drive. But when it was at 4.7, this is not the kind of patient you want to continue to have that drive. You want to be able to try and address it and try to reduce the drive any way you can, because they still need a bit of oxygen and PEEP, and it's important to try and reduce that drive. Now, PEEP can sometimes affect drive in a negative or a positive way. So you can try affecting the drive by adjusting PEEP. However, if that does not improve or reduce the drive, you need to find other means of doing so. Now let's look at cycling of the ventilator breath. Here we have a patient in pressure assist control with an inspiratory time of 0.8 seconds. As you can see, the 0.8 seconds is holding the pressure, but at the end you're seeing a pressure that's rising. Now this can be due to active exhalation, or sometimes just passive relaxation of the respiratory muscles can cause a little bit of a spike here. One way to determine whether or not it is active and the patient is really trying to end the breath at that moment is if you have an abrupt spike in expiratory flow. Let's look at an actual ventilator waveform screen to see what that might look like. Here you can see there's a drastic increase in pressure, which is caused by delayed cycling. The patient wants to exhale, but the machine has not cycled off yet. And as you can see in the expiratory flow, there's a rapid increase in flow at the onset of exhalation, indicating that there is some force behind it. Now, by shortening the inspiratory time to 0.7 seconds, you can see there's still a tiny blip in the pressure waveform. However, the rapid deceleration in the expiratory waveform is no longer present. Therefore, this is probably the optimal timing you're going to experience without overshooting and making the breath be too short, which is called premature cycling. With premature cycling, the patient's effort lasts longer than the ventilator's cycle-off criteria. So in this example, the cycle-off criteria again is 0.8 seconds in pressure assist control. It cycles off here. But as you can see, the patient is just not quite at the point where they are beginning to exhale. And therefore, there is a dampening in the expiratory flow waveform because the effort continues on past the cycle-off criteria. This can also occur in pressure support. If the cycling is set too high, the machine will cycle off before the patient effort is complete. Let's take a look at it on a real ventilator waveform. In this example, the cycle off percent is 60%. of inspiratory flow, which is too short, and there's clear evidence that the patient is continuing to inspire after the ventilator cycles off. Sometimes if the effort is strong enough, what can happen is the ventilator can sense that the patient wants a breath because the effort is strong enough to meet the trigger sensitivity criteria. And in this example, you can see a second breath is delivered to the patient with the same effort. Now let's discuss a very common form of asynchrony called ineffective efforts. Ineffective efforts generally occur when patients are over-assisted, either with too much pressure support, or if they have very high airway resistance, for example. So here in this case, we have a patient with a very weak effort that they trigger the ventilator, but due to their airway resistance, which is quite high, it takes a very long time to meet the criteria, which is 25% of peak flow, to cycle off the breath. So all of this breath is excessive compared to their drive. So this patient is essentially being passively ventilated by pressure support ventilation because it requires this criteria to be met prior to cycling off. Now, one thing you could consider is shortening the time, which of course will cycle off the breath. But if the peak flow is being met by the patient, it may not stimulate them to actually make a stronger effort. So usually the first step when you have this is to assess your tidal volume, which here you can see it's over 8 ml per kilo. Now, it's only picking up 17 breaths per minute, but the patient that I've set up here is actually breathing 28 breaths per minute. So they're a little bit tachypnic. So the tidal volumes they're probably would be bringing in would be a little bit lower than this for sure. So let's see what happens when we reduce the pressure support. The P0.1 was 1.4 and now it's increasing to 2, just over 2. So the patient's drive is increased. The tidal volumes are lower, but still acceptable considering the respiratory rate of the patient. And as you can see, they're now cycling every breath and triggering every breath. So you have to consider that the patient effort has a lot to do with whether or not the machine is over-assisting and taking too long to cycle off. So that condition I described was delayed cycling, which is actually the number one reason for ineffective efforts to occur. And in fact, one of the mechanisms people think is the problem is the trigger sensitivity. Now, unless someone has set it abnormally high, the default trigger sensitivity on most ventilators should be sufficient for a patient to trigger. So if the patient cannot trigger a breath, look for signs of delayed cycling as I've just described. Finally, I will discuss the asynchrony type called reverse triggering. It's complicated to understand, but very common, so it's worth noting. Reverse triggering is different from normal patient-ventilator interaction. The normal way a patient and ventilator interact is that the patient triggers a breath from the ventilator by setting off the trigger sensitivity. In reverse triggering, the ventilator delivers a breath first without patient demand, but then that breath that's being delivered triggers, or rather stimulates, an effort from the patient. It's very common in sedated patients or those transitioning off sedation. But whether it's reflex or just bad timing is up to the clinician to decide by making ventilator adjustments. When it's reflex, it can be difficult to manage. There are things to try, which I'll review, but sometimes those things that you can try may not be safe to do in a patient, for example, with acute respiratory distress syndrome. Or, in other words, patients with COVID-19, it may not be ideal to do some of these maneuvers in order to try and relax the reflex. Now, just to clarify, reverse triggering does not require a ventilator breath to be triggered in response to that patient reflex. However, it can happen, and this is called breath stacking, which I'll describe in the next slide. So reverse triggering, as you can see on the left, the machine delivers a breath, and as you see, there's an esophageal pressure waveform in the bottom that indicates the patient's making an effort after the ventilator delivers a breath. So in this example, the patient is on a volume assist control mode that actually allows the patients to pull flow from the ventilator, even though it's supposed to be controlled, but only when they demand and have a huge drop in pressure, which you can see in the second breath, which is why flow is delivered to the patient. On the one on the right, they're also on volume control. They're triggering the first breath. The second one, the machine comes first, and then the patient makes an effort that, although it may be difficult to see in the inspiratory pressure waveform, although there is a loss in plateau, which you can clearly see that the effort continues on into the expiratory phase as there is a large increase in flow as the patient is making an effort. All of the phenomenon in these slides, or in these graphics, except for the first breath in the image B, are all reverse triggered breaths. The final one is the only one that actually resulted in a second delivered breath, which is called breath stacking. But reverse triggering, the term itself, does not require a breath stacked breath to occur in order for it to be classified as something called reverse triggering. Now let's demonstrate. The first thing to do is to first see, is this reflex or just bad timing? If you look at this paused waveform graphic here, this is volume assist control. You can see the effort is represented by this pink line here. And the machine delivers a breath, and the patient responds with an effort afterwards. Now in volume assist control, you're looking for changes in pressure. So you can see this scooping that occurs here, but not at the beginning of the breath. So this could be classified as a reverse trigger. The machine comes first and stimulates the patient to make an effort. Same with this breath here. The machine comes first, the patient makes an effort, and the effort continues on past the point at which the breath cycles off, and you can see this little dampening in the expiratory flow. So if you saw this sign here in volume assist control, or a drop in pressure here, you may think that the patient has reverse triggering. Now, is this bad timing, or is this truly a reflex action? The first thing to do is to simply reduce the respiratory rate. So if I reduce the respiratory rate, let's start up the simulator here. If I reduce the respiratory rate to 10, I can see if my patient has an intact respiratory drive, and perhaps I'm just beating them to the punch. So now that the ventilator rate has been reduced to 10, you can see my patient is triggering every breath. So this patient no longer has the phenomenon known as reverse triggering. All it was bad timing. So that's one way to determine whether or not the patient has reverse triggering. However, in many patients, when you reduce the rate, the phenomenon of reverse triggering continues. And of course, reducing the rate would reduce the minute ventilation, and this may not be appropriate. So let's discuss actions to take if you reduce the rate and the patient continues to reverse trigger at the lower rate, and therefore you lose valuable minute ventilation. So if you've already reduced the respiratory rate and the patient does not take over with sufficient minute ventilation, turn off sedation when applicable, or if it can be done. Otherwise, if you cannot, increase tidal volume to a maximum of 8 milliliters per kilogram of ideal body weight if it isn't already at that level, keeping in mind that we should keep plateau pressures less than or equal to 27 centimeters of water when possible. Now in COVID-19 patients, the recommendations are to follow those of typical ARDS guidelines, which is to minimize or limit plateau pressure less than 30 centimeters of water. Now, if there is a known injurious pattern and you cannot correct reverse triggering, and the injurious pattern I'm speaking of is breath stacking, for example, and if medical management is still a concern, in other words, you cannot turn off sedation, then consider the use of neuromuscular blocking agents to protect the lung and minimize the possibility of barotrauma.